EM board bombs.
Welcome back to EM Board Bombs. It's nice to see you, Dr. Briggs.
Pleasure to be here.
A 32-year-old male is brought into the ED with a gunshot wound sustained after his friend was inspired by the Olympics. His friend who was with him, the one who accidentally shot him, states he was watching the Olympics and was fascinated by the shooting competition where the Turkish individual won silver. He was looking at the now viral picture of the Turkish shooter.
We don't know his name.
Who had one hand in his pocket. One hand in his pocket. Do you remember this picture? It's amazing.
Yes.
No protective eyewear and only one hand on the gun. And everyone else next to him was like fully kitted out. Well, unfortunately, your patient's friend was obsessed with recreating the scene. And again, unfortunately, he chose to use a .44 Magnum revolver, which is, to those of us who have shot one before, it's notorious for its substantial kickback.
Yes.
And it resulted in an erratic shot, accidentally shooting his friend who was next to him. So, yeah. On arrival of EMS,
cue the NBC music.
Cue the NBC.
The Olympic theme.
Right. There you go. Insert.
Should have led with it.
Please. On arrival of EMS, he's awake and alert. Airways intact. Respiratory rate is 40, and O2 sats are 84% on room air. Exam reveals a large wound in the right chest with air audible from the defect during respiration. What is the best next step in management? Is it A, insert a large bore thoracostomy tube through the wound? Is it B,
40 French or go home?
Is it B, perform needle thoracostomy in the second intercostal space of the midclavicular line? Is it C, place a 3-sided occlusive dressing over the wound? Or is it D, transport for immediate stabilization in the OR rather than the emergency department? I know. We always lately we've been throwing in that one option,
throwing the easy one.
just to like hear some chuckles.
Yeah. Yeah, did you know the OR can directly admit?
Oh, stop. Hey, so before we get into the right answer, that was a cold open, and we just wanted to get into the question stem.
Welcome back to EM Board Bombs.
Yeah, EM Board Bombs.
Again, cue the Olympic theme.
There you go, EM Board Bombs.
Yeah, Paris Olympics.
EM.
We're not sponsored, by the way.
Rapid Bombs. You can find it on our website, emboardbombs.com.
Yeah.
Click on the question bank there, and you'll be able to sign up for our exclusive board review podcast, life review podcast. We drop multiple episodes a month, so it continues to get larger and larger over time. And you'll get custom emails delivered 3 times a week, spaced repetition by our own Dr. Marlena. And
she puts up with how dumb we are.
She does. She really just puts up with this. And lastly, we're going to talk about EM News. EM News is our only sponsor, the only one we take. We have said no to everyone else. And again, to those who continue to reach out, stop. Reach out to us on social media and other stuff. We're not joking when we say we're not. You can, we've been made offers. Just say no. It's like DARE. To those who remember the campaign for DARE, don't do drugs.
Oh my God.
Just say no. That's what we say. EM News is the only sponsor we take. Go to the website. It's pretty awesome. Find great articles. You can even get papers delivered to you. So if you want to act really smart, you can be on an airplane with an EM News kind of paper article, just like spread it out and read it. Anyways, we love EM News. Shout out to them. Hey, Briggs. So we've talked about EM Rapid Bombs. We've talked about EM News.
Everyone's forgotten the question.
And everyone's forgotten the question. Yeah, so in short, remember, you have this 32-year-old guy. He's got a gunshot wound. And
chest ball.
Yeah. What is the right answer here? What's the right
He has a sucking chest wound.
Sucking chest wound.
Love when people say that.
What's the right answer?
Correct answer here is going to be place a 3-sided occlusive dressing over the wound.
Got it.
So the key to this question is that he was in the field.
Right.
and this is one of those important field EMS questions you're going to get on the boards. So we're going to focus on some immediate life-threatening injuries for chest trauma. And by chest trauma, we're talking about the box, a term you may have heard a bunch.
Yeah, you're really excited by this, and I'm really happy you are.
Oh, no.
I don't know why I'm not excited.
I think this is much more exciting than mastitis, which you've been trying to do.
I've been
for
trying
the
to
past
do
month.
mastitis, and I have a question
And
ready
that is
for it
pretty
for
awful.
literally like
Pretty
2
awful.
months. Because I feel like
Yeah, but
it's something that we should be able to handle.
yeah, do you know how much that's
appropriately.
going to hurt our numbers?
You think the box? You think? I guess you're right. I mean,
People are going
like,
to click on this
it's
and
like
be like,
EM
oh, wow,
crit.
chest trauma.
Yeah, EM
Yeah.
crit. It's like always like this, like great. You know,
Yeah.
like people are
You
so
gotta know what to do.
excited by that
No, you
stuff.
got to know what to do. This is sick. This is trauma season, baby. Holiday season for trauma right now. Summer. It's hot outside.
Okay, you're okay. Fine. Let's get into it.
Yeah.
Gosh.
Right. Our listeners, trust me, they'll let us know. They're like, would you like to go to a lecture today in didactics on chest trauma or mastitis? What do you think they're going to say? What do you think they're going to say?
What do you think they're going to encounter though? What do you think they're going to encounter?
What? I think we can both agree chest trauma in the United States is much more common than mastitis in your average emergency department. Oh, it absolutely is.
Do you think so?
Oh, absolutely. Blunt and penetrating chest trauma together.
I think I'm gonna have to look that up. But anyways, continue, Dr. Briggs.
Oh yeah, okay. I think we can fact
Let's
check
talk about the box.
Let's get our best people on it.
Yep.
So we're talking about the box. So your job as an emergency doctor is to rapidly assess these injuries.
Hmm.
And let's be honest, there's only a few we have to be aware of, though.
Yeah.
So we're not talking about the ones that the classic, they go to the CT scanner and then an hour later, a radiologist says, hey, there's a 1 rib fracture, the 6th rib. That it's not something you need to worry about. Or the, hey, 3 hours later, hey, they might have a non-specific finding of their bronchioles or something.
God.
That's all stuff that needs to be addressed
Get a
upstairs.
repeat CT in 3 to 6 months.
Exactly. We're talking about the major injuries, life-threatening injuries. We're going to really summarize this in a second. But first, let's just talk about the general overview here for new listeners and also just people that don't see trauma regularly. That's really important.
Yeah.
One, we have 2 types of overview of trauma here. Why don't you cover penetrating?
Sure.
And then I'll cover blunt.
Yeah,
Go ahead and
yeah,
cover
I think that's
penetrating.
good.
What is
So-
the difference in thoracic trauma when you see these patients?
Yeah, so all right, let's divide it into 2, penetrating and blunt. I'll talk about penetrating, more likely to require surgery, right? Less injuries overall, but it's going to be more specific. So more unique to penetrating, like examples, cardiac tamponade, diaphragmatic injury, esophageal injury, tracheobronchial injury. Those are those kind of penetrating thoracic trauma injuries. And then you have blunt.
Perfect.
That's like the one we see a lot more often, right? It's that MVC that's coming in. It's much more common. Someone falling off a horse or something. More variety of injuries overall, more unique to blunt trauma again. And those specific injuries are going to be like rib fracture management. How do you manage like sternal fractures? How do you manage pulmonary contusions? How do you manage cardiac contusions?
Right. And we're not really going to get into anything we just mentioned on any of those.
Yeah.
So we purposely left out 2 injuries. You mentioned cardiac tamponade, but really the pneumothorax is one we didn't mention because that occurs in both of those relatively frequently in blunt and penetrating trauma. Yeah. So what is the box when we refer to trauma? I know you rolled your eyes big time, but what does that include? Simply put, it's not just the chest. It's the side of the chest. It's the back of the chest, meaning the back.
Right.
But it's going to be the superior marginus, clavicle sternal notch. You're not going to be tested on this, by the way. We're just telling you the borders. Yeah. The lateral is the nipple line, and then the inferior is the costal margin. So it's much more than what you think it is.
Yeah.
So an injury to the back, obviously, we both know can injure the heart, can injure the lungs, of course.
Yeah.
We're not stupid here. So what I guess the main question to go further here is, what does patient is stable really mean? And I ask residents this a lot, especially before a trauma patient does come in, is I'll ask our emergency medicine residents or students that are working with me, and we talk about what really stability is. And essentially, we always limit ourselves to saying...
Do you ever get like a deep response?
Very deep question. Oh, yeah.
What,
Dr. Briggs, what are you
What if
reading?
you said, like, what is stability to you? And they were like,
ooh,
well, I think a work-life balance.
Yeah, exactly.
And
a regular paycheck. Yes.
You're like, no, I meant...
Good dental care.
I meant for the
good
patient.
dental benefits. Yeah, for the patients. So often we think of patient stability as the blood pressure. We'll say a heart rate of 110 is really not much. Yeah. But in reality, in so many patients, that says a lot. So any vital sign of normality or just altered mental status alone should raise suspicion for a deep underlying injury or chest injury. And what's fascinating, and we both know this, is that hypotension is so rare early on in trauma. And that's because, especially due to young people, especially due to penetrating chest trauma, which is more common in young people, and it's due to their age, their hemodynamic reserve, their adrenaline going, their sympathomedics could be on board too, but their sympathetic nervous system in general is more active during that trauma that just
Usually
happened.
when the hypotension's happening, you're behind the
It's
eight
really
ball.
late. Oh, you're really behind.
You're like
Exactly
you're
right.
like playing catch up.
You're a few liters deep of blood.
Yeah.
But anyway, but that tachycardia, non-specific tachycardia, may be the first sign, or maybe that borderline hypoxia at 92, 91. Anyway, so just always remember that hypotension alone does not automatically. It's not going to be there. So if you're limiting yourself so much to hypotension to act on things quickly, you're going to be behind the eight ball big time. And that leads to a second point. Why don't you talk more about these ABCs? I know this is a nuanced discussion here, but we just want to mention it to new listeners, to people who are also not seeing as many trauma patients, but it's always important to consider maybe a different order, right? Rather than what Sesame Street taught you.
I mean, yeah, sure. Yeah, I mean, you're going to get into the whole Sesame Street thing. I mean, they did the ABCs, but in the case of chest trauma, sometimes it's better to CAB or BAC, right? So addressing a pneumothorax with a chest tube or giving blood products, that might take precedence over intubation.
Sure.
Because you going to intubate might just kill the person.
For sure. Exactly.
So that's why you have to sometimes go in that order. So let's review out of hospital chest trauma in the field. This
was a question we gave you.
Yeah, this is the question we gave you, right? Common scenario, common kind of board test question. So you're going to get some sort of question about EMS calling you from the field, asking you what to do with the patient with chest trauma, and there's some sucking chest wound that the patient has from penetrating trauma. This is a classic question. This is one you should easily be able to knock out the park. So talk about this. For a sucking chest wound, they'll use that terminology. This is what?
An open pneumothorax.
Open.
They
love asking about this stuff.
They love asking this. You will get this more in tests than in real life. Yeah. You know the number of times I've seen occlusive field dressing.
Dude, I know.
It's so funny, but it's so true. Like you can count the number of hands. Oh, was that the chest wound?
No, I was clearing out like a little thing.
Oh, okay. That was funny. Can you please imitate a sucking chest wound? Charades.
I'm glad you asked me.
Ooh, that's really good. That's some ASMR for our listeners. They love that stuff. People love that stuff on YouTube now. That was a little too sensual, I agree. So anyway, air enters the pleural cavity in an open chest wound rather than, through the lungs and the trachea, of course. And what you're going to do here is you're going to place an occlusive dressing over the wound and then secure it to the patient on 3 sides. The importance here is 3 sides. If you do 4 sides, you're just converting it to a closed pneumothorax. You didn't really help anybody. So open on 3 sides. And essentially this occlusion converts the open pneumothorax to a closed one. The 4th side is left open to allow the escape of any air building up in the pleural space from the associated pulmonary tree injuries. And this is really important, especially if the patient is already intubated, and to prevent a tension pneumothorax from happening. So in summary, you got a sucking chest wound in the field on your test question, or let's say they arrived at the bay and there's nothing on them yet. You're putting a 3-sided occlusive dressing immediately on that patient. And then, of course, you can put a chest tube in later if you're the person doing that after you do your primary assessment, secondary assessment, depending on the stability of the patient. So let me quiz you on something.
Yeah. Hold on one second.
We haven't talked in a while. Get loose. Stretch a little bit. Get loose. Yeah. All right. You stretch out. You ready?
Let's do it.
Ready for me to put you on the spot? All right. So in chest trauma.
Yeah.
The most common injury associated with chest trauma is which of the following? Hemothorax, pneumothorax, cardiac tamponade, vascular injury, or endobronchial injury.
Pneumothorax. This is going to be pneumothorax.
Yeah, it's very easy, isn't it?
Yeah.
That's great. I just had to ask you. I just want you to hold your breath for a minute.
Oh, man, I thought...
Keep you on your toes.
Something crazy was going to happen. All right.
No, keep you on your toes here. So back to your job as an emergency doctor. Your job is to rapidly assess, as we talked about, for 3 major issues within minutes of that patient being in the ED. And you can do this as an emergency doctor. It's very easy to do this. 1, you're going to look for a tension pneumothorax. We're going to talk about how that is in a second. 2, you're just going to see if this patient is spontaneously ventilating, meaning do you have to intubate them immediately? And then 3, of course, you're looking for a cardiac tamponade with the ultrasound. And we're not going to talk about the cardiac tamponade on this episode. We have a part 2 coming up, which should be interesting. But we're going to focus on the ventilation and the pneumothorax here.
Yeah, and I think just low key, the cardiac tamponade, though, is like low-key one you can really save lives, if you recognize that real quick.
Of course.
Just FYI. Yeah, let's talk about pneumothorax more. So it's tension
Sneak
pneumothorax.
peek to the future episode.
Yeah, exactly. So let's talk about pneumothorax here. Attention pneumothorax is really just improperly defined. So the correct definition is pneumothorax with significant improvement of vitals on decompression. So what does that mean? Don't get Dr. Briggs started on when tension pneumothorax is diagnosed by a radiologist. We won't talk about that. So the old school definition.
I love when they call.
I know I'm not. Just don't get started. I'm holding you back. That's why I'm doing this part.
Hold me back.
Okay. I'm holding you back, Dr. Briggs, because I know
I'm calm. I'm relaxed. I'm in a zen.
Just stop. So the old school definition with was a tension pneumothorax meant that there was hypotension or air hiss on needle thoracentesis or chest X-ray finding showing tracheal deviation. And obviously Dr. Briggs's favorite, decreased breath sounds. For clinical practice, you need to forget what you learned. Again, clinical practice, you will not see the following signs reliably. Tracheal deviation is unreliable. My gosh, I've been doing this for like over a decade. You've seen it? This tracheal deviation thing, I'm like, okay. So breath sounds are unreliable. We know that.
Yeah, exactly.
That everyone knows, right? Chest wall.
Everybody mix it up.
Yeah. So chest wall observation signs are variable and physician dependent. And you need to go with clinical suspicion or ultrasound or just empiric decompression. And in reality, look, the ED, it's a loud place. There are a lot of bells, whistles, and things happening. You're not going to trust if breath sounds are present or not. How many times have we all seen that healthy, young, lanky patient walking in, and they've got a lung that's completely down and they're satting like 92% and just have like a little bit of an elevated respiratory rate, but you're hearing breath sounds. So symptoms are often related to the volume of air present, in the pneumothorax. So continue, Dr. Briggs.
Yeah. So traditionally in the trauma bay, or in a lot of patients that are coming into the ED voluntarily via private vehicle, they're going to get some type of upright chest X-ray.
Yeah.
And that's your traditional diagnosis.
Sure.
Unfortunately, that can miss a lot of that. The sensitivity really ranges between like 28 to 75%, which is quite a range.
It's huge.
The upright anterior posterior X-ray, the air will collect obviously in the apical regions, depending how large the pneumothorax is. A supine X-ray is really bad, obviously. It's just worthless.
You got to get them up.
And so, so obviously you and I can both imagine here the common scenarios are trauma patients are going to be supine anyway because of a potential back injury, or they're just supine in general. They come in on a stretcher, they're supine or semi-recumbent. That's going to lead to this not being that good. That's where POCUS comes in. This is not one of those podcasts that's going to tell you that POCUS can save the day on every single thing.
Yeah, that's
we both
not
like
us.
POCUS.
Blue collar,
no, it's
baby.
not us.
Yeah,
blue collar. We like it. We use it, but we certainly are not. How do we put this?
Yeah.
Yeah,
we're not walking around.
That's all we're going to say.
Let's be respectful of our colleagues. We love them.
Let's be respectful. We love it. It's educational. Yes. I teach using it almost every shift, but we both realize limitations. However, in this case, it probably does beat out the X-ray pretty well. The sensitivity specificity is at least 86, 97%. It's really, really good. Yeah. And so if you're ever unsure, you got an unstable patient, of course, it's going to be part of your FAST exam. You're doing a quick view for lung sliding, and you're looking for obviously lung sliding, lung point. It's faster than getting an X-ray done if you have ultrasound machine right there in the bay with you. Just practice with it. The more you practice, the more you're going to get used to seeing lung sliding. You're going to feel confident that this is not a massive pneumothorax causing your patient's vital signs. So really getting into that, how to stop missing a pneumothorax. You should always have that in the differential for any patient in respiratory distress in the trauma bay. That's an obvious one. It's more of a disorder of respiratory distress than hypotension. We talked big earlier about how hypotension is such a late finding, and it may just not even be there in someone with a large pneumothorax. And then the majority seem to decompensate over a long period of time, so they're not going to sometimes come right away, and you're going to say, oh my gosh, got to rush and needle decompress the chest. It just doesn't happen that much. Same with the hypotension. So who's unstable and who's going to need an emergent intervention? So who's unstable here? This is pretty straightforward. But obviously, we're going to leave out the part about hypotension. Of course, anybody with a systolic less than 90, obvious. Anybody with an oxygen saturation less than 92%. anybody with an excessively high heart rate, anybody with a high respiratory rate. It's pretty much straightforward here. If you can't speak in full sentences and or have a really high heart rate or low blood pressure, you need to have your pneumothorax addressed. That's pretty much it. I mean, that's what it comes down to emergently either needle decompress or put a chest tube in. Now, I know some of you are listening out there and saying, well, I haven't done a needle decompression in years. I don't know why we talk about this. Well, unfortunately, it's still talked about in the boards. It's still a board testable thing. It's still something in the field that is taught, of course. Why don't you get into the downsides of needle decompression? Because we're going to recognize the fact that in real life, we don't really do this in the hospital anymore. Sure. But why don't you recognize it and just say what the test, we'll talk about the test answer, and then we'll talk about the real life. Real life.
So real life, normal IV catheters, they're not going to reach where they need to reach, like 65% of the time. And that also might depend on the part of the U.S. you're practicing, where they really might not reach, depending on the region, depending on the amount of adipose tissue that they are going through. So chest wall thickness.
That was very respectful of you.
That's what we do. We're a respectful podcast. 30% of trauma patients have a chest wall thickness that's greater than 5 centimeters. And so
it's also very subtle.
Yeah. So average IV catheter is like 4.5 centimeters.
So it's not going to reach.
Yeah, it's not going to reach. So too long a needle can damage structures inside the heart. So, you're not really busting out an LP needle for this, or a harpoon. And then needle versus finger thoracostomy is, we're not going to get into that. Okay. I'm sure there are certain types of podcasts people listen to and they're like all about the whole like finger, whatever. Cannula may kink, occlude, or compress, right? Because it's tiny.
Right.
So,
So in real life, you're just not going to do it.
You're not going to do it.
And in real life, if you're in the trauma bay, you are putting a chest tube in a patient that needs a chest tube, that needs their pneumothorax addressed. However, on the test, and I tell residents this all the time on your boards and students as well, if you have a pneumothorax on the test question and they're giving you options of what to do, if it's an unstable patient, which is all it is, it always is an unstable patient. They always tell you it's a tension pneumothorax. 100% of the time, you're putting a needle in.
Yes.
You're doing a needle decompression, and you're going to follow up later with the chest tube.
Yes.
It sounds silly. It's dumb. Yes, it's outdated. We all get that. It doesn't matter. Unstable patient, the test question is still telling you your immediate relief is putting a needle in. Correct. And then following up with the chest tube. Okay, great. Glad that done. Speaking of chest tubes, we got to stop using big tubes.
Yeah, really. Seriously.
This is pretty absurd.
And they're downstream sequelae of this as well.
Oh, honestly. It's awful.
Yeah.
It's awful for the patient
like
too.
expansion.
Yeah.
Pulmonary edema is from all the expansion, but using too large of you don't need like a massive tube. Yeah.
You never do. So less than or equal to 20 French chest tube is fine for hemothorax, depending on what you have, but never go bigger than that. It's absurd. Yeah. And then anything for pneumothorax, you should be doing catheters for pneumothorax only. Small bore catheter, like a 12 French. That's it. Quick thing about hemothorax, because people ask about this a lot.
Board question too,
sometimes. Also board question, yes. This is usually caused by intercostal blood vessels, and it's usually associated, of course, with the pneumothorax. They're, of course, then called a hemopneumothorax. Typically, you're going to have to see quite a bit of this to follow up on a chest x-ray, but most of these patients are getting CT, and it's discovered, the full scale of it's discovered afterward on the CT. Right. The reason we care about these hemothoraces, one, if they're actively bleeding, of course, it's a source of instability of the patient. Two, just the collection of that blood there can be a huge negative for ventilation for the patient. It may not reabsorb all the way, and it eventually leads to infection, empyema, and eventual pulmonary fibrosis. All this stuff's bad. Yeah. So hemothoraces are more likely to be drained than putting in a chest tube. So what's the board question
when it comes to like hemothorax and indication for surgical thoracostomy?
I hated this question all the time because I never memorized it. Yeah. Now, there's a number I'm about to tell you that's like the board answer for surgery, but I'll be honest with you, I was going over some review questions the other day, and I just stay fresh, got to stay fresh. And fresh. I'm going to stay fresh. And there was a question on this, and I'll be honest with you, I forgot the number of what is OR, like the OR number, and I got it right because it was like an obnoxiously like large number. Yeah. I think it was like 2,000 or something. Yeah. And I was like, okay, well, that seems pretty like, obviously they're hinting at the fact they want you to know the patient needs to go to the operating room. There's all these other choices of like switch out the tube to a bigger size or intubate the patient, like all these other things. And the answer, of course, is just go to the OR. Yeah. And so that's what you need to remember here. So I wouldn't really remember the number. We'll tell you it's 1,500 milliliters. And that's, if you have an immediate bloody drainage of that, 1,500 milliliters, that's considered an indication for surgical thoracotomy. Again, there are a lot of nuances with this. I've met so many surgeons that don't go to the OR based off that number, based off many reasons, or go to the OR on a smaller number. So we're trying to tell you not to memorize that number. And on the boards, it's just remember, it's a big number, and they're going to give it to you pretty easy. That's the whole point of them asking that question. They're telling you, oh, wow, a lot of blood's coming out. What's your next move, champ?
Champ.
So champ, they're going to call you champ. Anyway. And of course, another thing is like any persistent shock. And if it just keeps bleeding over the course of an hour, even if you don't reach the 1500, that's another indication too. One other thing that's interesting, and this is where we're going to end, is something that that has changed my practice over the course of the past year, is me learning about the necessity of giving empiric antibiotics or prophylactic antibiotics.
Tell me about this, because I have not incorporated this into practice.
So at our institution, we've started doing this, and we've discovered through studies that the initiation of ANSEF before you put a chest tube in substantially reduces the risk of empyema in the trauma ICU days later. I didn't believe it at first. I saw that being given. I was like, this is a little wasteful. It's like the Castillo criteria for open fracture. You're like, okay, come on, let's be realistic here.
I did a deep dive into that recently, the whole ANSEF and like fractures and like, why are people doing it for like bogus. They still like finger open fractures. But anyways, continue.
Bogus. But no, I looked it up and reviewed it, and based on what I'm seeing, this is pretty legit. And it actually, if you can, I mean, obviously we know the two big peaks of death from trauma. Death number one is you die from the trauma within the few days, and then 2 weeks later, you die from sepsis, from infected wounds, things like that. And so I was talking to a surgeon about it, and then I was looking up online, and it checks out.
What is
to
it,
me.
a gram or
I've
two?
started doing it. Sorry?
A gram or two of ANSEF? How much?
Yeah, something like that. Yeah.
Nice.
I think it's a gram or two. Honestly, I don't memorize it.
Yeah.
I just tell the pharmacist to please get me some.
Of course, as usual. Thank God for our ED pharmacists.
Yeah, exactly.
They're
putting up with what we do.
Sometimes like patients like should literally give them high fives on their way out.
Yeah, they should. They save lives. Hey, so this is part 1 of chest trauma done. Part 2 is coming up.
Yeah.
In the future. We're excited. I know you're really excited.
Sure.
Oh yeah, this is definitely less exciting than mastitis. Wow. Okay. Let me tell you what mastitis episode is going to be. The patient has mastitis. All right, what antibiotic do you want? Okay, augmentin? Great. Okay, go home.
No, and what should you continue to do? Anyways, all right. So
continue to breastfeed? Okay, great. The question's done.
Anyways, so Briggs, that's pretty much it. Hey, can we do like just a super quick summary for the TikTokers?
Sure.
I think we have a TikTok or something.
Okay.
Just do like high level summary.
Okay, high level. Ready? All right, ready. Let's go. All right, chest trauma. In a nutshell. Penetrating and blunt trauma. As an emergency doctor, you're looking for spontaneous ventilation, pneumothorax, cardiac tamponade. You can look at those 3 really, really fast. Remember that sometimes it's not always ABC. Sometimes you got to think about chest tube before intubating. Sometimes you got to think about blood products before intubating. For a pneumothorax, remember that the hypotension, the tracheal deviation, the decreased breath sounds, all that stuff's really unreliable. Even an upright chest x-ray is going to lie to you, especially if they're a supine x-ray. That's pretty much worthless. So use your ultrasound if you can, if you're unsure. Always look for those secondary vital signs. They're probably not going to be hypotensive ever. They're probably going to actually be in respiratory distress. I can't speak in complete sentences. They feel uncomfortable laying flat, and they're telling you, like, I can't breathe laying flat. They may complain of shortness of breath, but they're going to have tachycardia, and they're going to have hypoxia, typically less than 92%. For these patients, for just a pneumothorax, if you decide to intervene on the test question, it's do a needle poke first, followed by a chest tube. In real life, it's just do a chest tube. And by chest tube, I mean chest catheter. For plain pneumothorax, you should never be using large bore chest tubes anymore. You're using a 12 French catheter or less. How funny, actually. Everything's French, and it's the Paris Olympics right now.
Continue.
Everything's measured in.
Just don't give them too much credit. Go.
And then for hemothorax, again, don't do large bore tubes anymore. Less than or equal to 20 French tubes is reasonable for hemothorax. And remember, indications to go to the OR for hemothorax. The textbook answer is 1,500 milliliters, immediate output. But really anything large on the test question, they're going to be hinting at you need to go to the operating room. That's it.
Great summary. Now we're going to do one more short and one more that's going to be a quick hitting one. Dr. Briggs, when are you placing a 3-sided occlusive dressing over the wound for a pneumothorax? When is that happening? Because boards love asking this question.
Yes. You get a call from an EMT in the field. They're asking you what to do with this patient. It is 100% put the occlusive dressing over. They always have an answer choice. They always have an answer choice of put a chest tube through the wound. Remember? And that is always the wrong answer. Never do that. It's so absurd.
Exactly. And what is that three-sided occlusive dressing? What is it like?
So what you're doing is you're taping a ABD pad or some type of thick sealant gauze with tape potentially over the wound. It's three-sided. So 3 sides are taped. 1 is left open, allowing that chest wound to vent. Good stuff. That was awesome. All right, check out Rapid Bombs. Go to ianborbobs.com, and we're signing off. We got office hours are over.
Well, for me, office hours are just getting started. So
That's wonderful. Enjoy your office hours. I'm off for the evening. Have a wonderful
I'm done.
night.
All right. Hey, Briggs, good to see you, man.
Good to see you too.
Bye.